And a warm welcome all you for this session of the topic for today's discussion is full mouth rehabilitation. And before going into this topic, we need to have some basic idea of the occlusion. Basic idea about occlusion. Now, this topic discussion, it starts with introduction and a brief note about the epidemiology, the etiological of the tooth wear, that is attrition, bruxism, and what are the changes that takes place in the occlusal table, a chronic bruxism patient, and what are the consequences of the bruxism, and the tooth brushing and the non-caries cervical lesions that leads to the loss of occlusion, that too in the posteriors. And the next heading will be diagnosis and management. How do you really manage the tooth wear? The various rehabilitative techniques that is in clinical practice. And the entire session, I'll enlighten you about the changes that takes place. It may be a physiological changing, maybe due to age-related changes, and abnormal oral habits or consequences of night grinding or a bruxism, which leads to a collapse of the occlusion, the occlusal table, wherein the patient needs a full mouth rehabilitation. Now, the attritional tooth wear is nothing but the loss of tooth structure due to friction with the opposing tooth surface. That is the definition for attrition. It is usually a common feature in an aged individual. It is an age-related changes. But if you notice any occlusal wear or tooth wear in a younger individual, it can be due to a bruxism, abnormal oral habits, parafunctional activities, and improper brushing techniques. These things form the major chunk of this pathological condition. Now we're looking into the epidemiology. The tooth wear is the most commonest cause of tooth damage when compared to the dental caries and a periodontal disease. This is the most commonest. The other causative factors can be excessive frequent acidic regurgitation, vomiting, or intermittent periods of bruxism can also be responsible for the tooth wear. It can also lead to enamel wear. Now, the severe tooth wear in three contemporary patients that leads to a collapse of the occlusion, and by the end it leads to a edge-to-edge bite. And you look at the picture, the clinical picture of a 50-year-old individual, wherein most of the lower anterior tooth is worn off and compared to the upper, and ends up with an edge-to-edge relationship or end-on relationship or edge-to-edge bite. And you can see the occlusal wear more pronounced in the posterior aspect of the occlusion. That is in the posterior, that is the molar tooth. And this picture shows about the severe attrition that is seen in the teeth, wherein you can see with pulpal exposure, the entire enamel and the dental is worn out with the pulp chamber exposed. That can be seen in a severe untreated condition. Look at the picture, you can able to visualize, see the entire dentition ranging from the anterior till the posteriors. All the tooth part is worn out with severe attrition with exposure of the pulp chamber. This is after a severe attrition. Now the causative reason, what are the causes, what are the etiology of the tooth wear? Mainly, if it is a gradual chewing, age-relatedly, it can be a functional activity. Okay. And if suppose any abnormal habit is there, that is any parafunctional activity is there, like your bruxism, night grinding, lip biting, teeth clenching, or these parafunctional activities can lead to tooth wear. If the pattern of the mandibular movement, that is your canine guidance, your anterior guidance, and the group function, can end up with a tooth wear. If patient is consuming more of a acidic diet or a coarse diet, that can lead to enamel wear. And subsequently your dentin also will get worn off. The hardest part of your tooth structure is the enamel. And once when the outer surface, the enamel is worn out, then the next layer, the dental, will very easily get treated. And I said earlier, like if the disease with a reflex acidic reagitation or eating disorders or salivary factors for some individual, occupational environment, or oral hygiene habits, you can see if some individual, they will be very subsequently they'll brush the teeth more, they'll do more time for brushing, and various aspects of the modern lifestyle that can lead to the tooth wear, the attrition. And this is the broad etiological factors for early loss of your enamel. Now, one of the most important parafunctional abnormal oral habit or a parafunctional habit, bruxism or night grinding, it is defined as diurnal or a nocturnal parafunctional activity that includes clenching, bracing, gnashing, and grinding of teeth. Mostly that too in the sleep. And the prevalence of the bruxism is reported to be 20% of the adult population. The American Academy of Sleep Medicine defines sleep bruxism as a sleep-related movement disorder characterized by grinding or clenching of the teeth during sleep, usually associated with sleep arousal. It can be classified into two. It can be due in the awake or in the sleep bruxism. Okay, it can be centric or eccentric bruxism. That is the other. That is how it is categorized. A bruxism can be the daytime or the nighttime, or can be in the awake or a sleep bruxism, or can be centric or eccentric bruxism. This is how now regarding the first type, that is the awake bruxism, patient will be aware of the jaw clenching, and this too will be around the 20%, and is associated with the nervous tic or reactions to stress. Very voluntarily the patient will be knowing, and the real pathophysiology is unknown, although stress and anxiety can be considered as a risk factors for the awake bruxism, mostly in the daytime. And the next, the sleep bruxism, That is recently sleep-related movement disorder. It has been classified as a sleep-related movement disorder. There is very little evidence to support the role of occlusal factors in the etiology of sleep bruxism. Not a full literature. Okay, very limited evidence. And whatever may be the type of the bruxism, at the end, what is the consequences of the bruxism? It is well known that the enamel, the tooth structure gets damaged very fast. Even if the hardest of the part, enamel, there will be tooth destruction, breakage of dental restorations or a rehabilitation, and it can worsen up the TMJ disorders. And the other clinical symptom is a patient will end up with a early morning headache. And the warning loss of the restorative material, where of the any filling, if it has been done in the posterior aspect, there is a chance for the restorative material to get worn off. The next is the cracks that is seen in the posterior tooth. Some individual with implant, if he is continuing with bruxism, then there is chance for implant failures. And more readily, if it is any fixed partial denture is there, it can also loosen the implants or worsening of the retention. Now, how to diagnose the condition? It can be by elaborate questionnaire with the patient, evaluation of the wear on occlusal splints, or it can be readily assigned by using Brux score plates, or can confirm it with electromyographic recordings of the muscles of mastication, that too during sleep. If there is an hyperactivity, hypertonus of masseter or the lateral pterygoid or the temporalis, these three form the major masticatory muscles of mastication. And the electromyography recordings, the hyperactivity of the muscles can be very readily ascertained and can be confirmed, so that the diagnosis will be simple. And the other important factor responsible for a non-carious cervical lesion is an improper tooth brushing. And this is very, very commonly seen in a day-to-day practice, where the improper brushing will lead to cervical abrasion, mostly in the premolars. That is the ignorance or the knowledge regarding a proper tooth brushing with the patient ends up with a cervical abrasion. The most common site is the vestibular or the buccal surface. The causes of abrasion, erosion, and occlusal trauma. And now coming to the conditions individually. The abrasion is a wear of hard dental tissue by action of due to physical or chemical agents. Okay, that is what abraded tooth surface will. Now, the erosion is a long-term effect of acidic or dissolution of the surface part of the crystalline structures, most of a chemical nature, that is erosion. The next one is the occlusal trauma. Occlusal trauma can be due to the masticatory force of a significant magnitude and direction. That is a traumatic occlusion. That is most of the reason behind is, if suppose any hyperactivity of the muscles of mastication is seen, then you can see there is more of an occlusal trauma. Okay, the earlier one, the abrasion and erosion, that is due to the physical and chemical agents. Okay, but the occlusal trauma is more often associated with the muscular pathology. Now, what are the effects of the tooth wear? The effects is there will be generalized cervical abrasion with attrition. That too in the premolars in the molar region. When you see the picture, you can very well see how the premolars and molars are affected with the exposure of the pulpal chamber. Or in the lingual surface of the upper anterior teeth, that is caused by a erosion, mostly when acidic regurgitation or a patient with GERD. That is chemical in nature. Okay, the erosive part seen in the facial aspect. Okay, one is the lingual surface of the upper anteriors. The second picture denotes the facial aspect of the anterior tooth, wherein you can see the erosive effects that is mostly associated with consumption of acidic food substances. And the other associated ill effects of the tooth wear is the temporomandibular joint problems with headache, craniofacial pain, and severe sensitivity. These are the ill effects of the abnormal parafunctional activity. Now, regarding the TMJ disorders, the craniofacial pain, the more extensive tooth wear is considered as a potential threat to a functional dentition. There has been various studies on the issue related between the TMJ disorders, craniofacial pain, tooth wear. Though no fruitful outcome has come, pinpointing the exact single factor for this ill effect. And the clinical symptom, that is the severe sensitivity due to tooth wear, that is because of the loss of the outermost layer, that is the enamel, the dentin. The dentinal tubules will get stimulated very easily, which has the innervation, the nerve endings. And once when the nerve comes in contact with the outer surface or the local factors, that results in a severe sensitivity. Now, how to arrive at a diagnosis and the various strategies for the management of tooth wear are, first is like all other ailments, observation, monitoring, and palliative strategies are very, very important in containing this occlusal wear. The next level of correction will be rehabilitative strategies, the biomechanical factors, and various techniques, and how to replace the worn out structures, replacement or a rehabilitation of the enamel and dentin. And if suppose the patient is on a long-term chronic condition, then there's something called as a maintenance phase. Even after rehabilitating or replacing the missing part, if suppose the patient continues with the bruxism or the night grinding, then subsequently the end result will be the damage to the restored parts. So there is something called as a maintenance phase that is very, very critical for the clinicians. Okay. The need for the treatment. Okay. First of all, you should consider the degree of the occlusal wear in concurrence with the age of the patient, the etiology, symptoms, and lastly, the patient wish. Patient's wish. Okay. The management will depends upon the four things. When you see a patient with a severe occlusal wear, the parafunctional habit, then your treatment management strategy will depends upon the age of the patient, the amount of occlusal wear, and how severe is the symptoms to the patient. And the last one is the most important one is the patient's wish. And against that, we can't do any treatment for the patient. And next one is the history, the clinical examination, diagnosis, management should be in the focus of eliminating the causative agents and to strengthen the modifying factors. Okay. The central tenet of management is preventive measures followed by restoration, and last one is your prosthetic correction, prosthetic replacement of the tooth, worn out tooth or a missing tooth part. And the first one that has been told is the observation, monitoring, and the palliative strategy. Before definitive reconstruction procedures being carried out, you should ascertain the rate of progression of the wear, and that has to be assessed. More commonly, what will be the clinical picture is this bruxism or associated occlusal wear is commonly seen with patient of skeletal deep bite. Okay. And before going for any reconstructive procedures, you should see how severe the occlusal wear is and how severe is the deep bite is. And before going in for replacement, you should study the patient well and go for the modification of the skeletal deep bite, maintenance of the vertical dimension, the mid facial height, the lower facial height. Then you should think about the reconstructive thing, and can be a time consuming part. That is, like, you should observe the patient, that is observation, serial observation, using the study cast, because every now and then when a patient turns to you, if you want to see the real degree of the occlusal wear, and that can be very well measured with only a study cast. That too, if you want for a longer duration of observation, see, for example, for 6 months to 1 year, then each and every time when the patient comes, you should measure the degree of the occlusal wear, that too in the study cast. By this observation, you can come to a clear conclusion whether how serious is this occlusal wear and how fast is this and how far it is progressing before going into any replacement or a rehabilitative procedure. And that is very, very important when you treat a patient with a chronic illness. And before, like you can do an intermediate corrective measures. Okay, before venturing into a replacement, intermediately you can do some corrective measures, use of a desensitizing paste or a mild filling or a light filling can be done. And each now and then when the patient turns up, you can evaluate with the study cast, and we can measure the amount of occlusal wear and how severe it is. Now, as I said earlier, the observation, monitoring, and the palliative strategies, that is very, very important when you want to think about your success of this rehabilitation. The real success of the treatment depends how the clinician evaluates the pathology first. That is the trump card for your success of your treatment. The definitive restorative procedures can be performed when the patient needs. The severity of the wear and the potential for progression of great concern. The conventional method of replacement is like your fixed partial dentures. That is the mainstay for rehabilitation for long years. Now, the other factor that has to be considered in rehabilitation is your biomechanical factors. The effective way to increase the retention of a conventional, the FPDs, is to furnish the preparation with boxes and grooves or to include any parallel pins. See, most of the tooth structure is worn out. Now, the next point of concern for a clinician is how far the dentures and how far the fixed partial dentures remains in the tooth structure that is already worn out. That how do we enhance the retention? By preparation of boxes or grooves, or we can include any parallel pins. That will increase the retention of your fixed partial dentures. And the next area of concern is the splinting, that is the occlusal splinting should be avoided whenever possible. And it is not recommended in case of confirmed bruxism due to high risk of cementation failures. Okay, now after replacing the worn out tooth structures, before thinking about maintaining the habit, mostly by the use of any occlusal splints, you should that should be avoided. And if suppose any restorations has been very limited to any a single tooth, that will end up with a physiological tooth mobility. Even that has to be avoided. And the biomechanical factors, one is the retention is of prime importance for your success of the denture replacement. Next one is most of the time you should avoid using any occlusal splints that will end up with cementation failures that is most commonly seen in the day-to-day practice. Now, the tooth wear can be more pronounced in the anterior segment, the posterior, or for some individual, we can expect a generalized tooth wear. Okay, the anterior part, if you want to correct the occlusal wear in the anterior tooth, mostly in the lower anteriors, your management will be based upon the principles of forced intrusion and supraeruption of your posterior teeth. Like as I told you, most of your skeletal deep bite patient will end up with worn out of your lower anterior teeth. In those cases, if you want for a replacement before going for any rehabilitation, your management should be like intrusion of your upper anteriors and supraeruption of your posterior tooth, and that should be the prime area of correction. Unless you allow your posterior to supraerupt, there is no point in replacing the burnout anterior teeth. Anterior cobalt chromium removable splint. resin bonded cast, that is the cast partial denture, or composite palatal onlay. These things can be utilized if you want to correct the anterior tooth wear. Now, the take-home message should be, before correcting the vertical dimension, there is no point in replacing the worn out anterior teeth. Okay. Now you should allow the supra-eruption of your posterior teeth. Maintain the vertical dimension, the vertical occlusal cable first. Then, after attaining a good facial height, then there is a point in replacing the worn out anterior teeth, not before that. And the next is your, if suppose the patient is that generalized occlusal wear is there. Now the vertical dimension of the occlusion is increased only when the interocclusal space problems is corrected first. Now, if see, for example, all the tooth is worn out, the anterior and the posterior tooth. Now, correction of that is really, really difficult for the clinician, because the other problems arises, like replacement of the worn out structure. That will end up with a more increase of vertical dimension or increased interocclusal space. And even the aesthetically, it won't be compatible to the patient. Now, as I told you about the replacement, first you can think about the removable prosthetic techniques. Removable partial dentures with an occlusal overlays can be used to manage the loss of vertical dimension. First, you can think about the removable partial dentures. That too in a generalized wear, if suppose very few teeth is there, and that can be used as an abutment for over denture or a complete denture. The next issue is the cost factor. Most of the removable prosthodontic techniques are not expensive, so that can be readily available and very low cost. Okay. Now the other area of concern is how to maintain the vertical dimension, how to maintain the replaced tooth from the occlusal wear. There should be any frequent or a regular follow-up is very, very necessary, because that is not a single day treatment. Okay. The patient comes with a loss of tooth, you replace the tooth, send the patient. And mostly with the occlusal wear, the chronic conditions that to do due to a parafunctional activity, it is not a single day job. You need to have regular follow-ups and a careful clinical and radiographic examination of the abutments should be performed. You have to see how the condition of the abutment is, because the occlusal force will be too excessive. That is, it will damage the abutments very easily if the occlusal trauma is more. So there should be a regular follow-up, and you should check with the radiographs, that too of the abutment tooth. The other thing is like the maintenance is with topical fluid application or a dietary advice. And the next is the lifestyle modification. Even that has to be prescribed to the patient, because since there is no single factor, okay, it is a multifactorial disorder involves. There is no single point cause for this ailment. And the before multifactorial process, very difficult to identify a single cause. Usually, physiological, when it threatens the tooth survival, or if it is concern to the patient, can be regarded as a pathological condition. Now, before going to the maintenance part, okay, one thing is like after replacement or before going for a venturing into any treatment techniques, the decision to treat or should not treat should be guided by the patient's state or the perceived need. The real need is the utmost important. That is one saying, that is index for treatment. Okay, the necessity for the treatment. The severity of the occlusal wear and the symptoms that is usually associated, mostly the early morning headache, craniofacial pain, or tenderness pain in the temporomandibular region, and severe sensitivity. These four forms the major symptoms the patient elicits, and these things should be taken into consideration before venturing into any reconstructive techniques. And the decision should be determined by the amount of tooth wear and the potential for progression. Even if, suppose, as I mentioned earlier in the previous slides, even after replacing the tooth, the condition, the bruxism or the neck grinding or any parafunctional activity is severe, then it will naturally damage the replaced part also, the abutment tooth also. Now, before going in for the final rehabilitation or replacement, think it twice or thrice regarding the rate of progression of the oral abnormal habit. And I thank you very much for your patient listening. And I think that I would have enlightened you regarding this topic of full mouth rehabilitation. Thanks a lot.